Bismillahirrahmanirrahim. Today we will have case quiz number 25. Case data: 53 years old female joined a gym to improve her fitness. After 3 weeks of working out, she developed right lateral hip pain, which was not improving. Pain aggravated by lying on the right side. No history of trauma, fever, or stiffness of her hips. No pain in back or knees. Examination revealed. Assessment of her gait reveals no limping. Negative Trendelenburg test or sign. Marked tenderness over the right greater trochanter with full range of right hip movement. Investigations showed plain X-ray don't show any signs of arthritis with good joint space in the hip joint. So, what is the diagnosis? The answer is trochanteric bursitis. Trochanteric bursitis. Trochanteric bursitis. The diagnosis is trochanteric bursitis, which typically produces lateral hip pain that is tender to palpation, as in this case. Trochanteric pain syndrome (GTPS) is now being commonly substituted for the term trochanteric bursitis. Trochanteric bursitis refers specially to inflammation of the trochanteric bursa. The bursa functions normally to minimize friction between the greater trochanter and the iliotibial band, which passes over the bursa with various degrees of hip flexion. Variations in anatomy such as broad pelvis or excessive repetitive contact between the greater trochanter and right iliotibial band, such as in runners, may result in irritation of the bursa and generate pain. Patients typically will have tenderness over the greater trochanter with direct palpation. Pain may radiate down to the lateral aspect of the thigh. Generally, if patient has point tenderness over the greater trochanter, this is suggestive of greater trochanteric bursitis. Bursal swelling may be present, but this may be difficult to appreciate in many patients. Lateral hip pain can be reproduced with a flexion of hip followed by resisted hip abduction. Trochanteric bursitis seems to be much more common in females than in males. MRI and ultrasonographic scans potentially can be employed to differentiate gluteus medius tendinitis from trochanteric bursitis. Often, trochanteric bursitis is managed non-operatively. First-line management include relative risk from offending activities, iliotibial band and tensor fasciae stretching, gluteal muscle stretching, and anti-inflammatory drugs. Second-line treatment may include modalities such as ultrasound with various degrees of success. I mean therapeutic ultrasound. If these fail, or if a patient cannot tolerate the symptoms, then a local anesthetic and steroid injection into the point of maximal tenderness is the next step. Radiological confirmation with fluoroscopy or ultrasound improves accuracy of trochanteric bursa injection. Advise the patient to avoid lying on the affected side if possible. The majority of patients will improve with conservative management. Surgical intervention, however, should be reserved for individuals who fail to improve from non-operative treatment. Surgery can be undertaken either open or arthroscopically. Surgery involves a release of iliotibial band in combination with trochanteric bursectomy. Key points. In trochanteric bursitis, there is tenderness over the greater trochanter with direct palpation. It is more common in females than males, and local anesthetic and steroid injection into the point of maximal tenderness under image guidance is the treatment of choice. And finally, thank you very much for your attendance, and we will meet you tomorrow or the next future with case quiz number 26. Wassalamu alaikum wa rahmatullahi wa barakatuh.